Welcome to another episode of APSC-EECC Core Cardiology series, and today's topic is about Channelopathies, Pericardial and Myocardial diseases, and CVD in non-cardiac surgery. Okay, please, next slide, yeah. So a little bit about APSC-EECC Core Cardiology series. This is a collaborative effort between the APSC and the EECC, a webinar series that is designed to provide comprehensive updates on various core cardiology topics. Also good as a preparatory for cardiologists in the APSC region planning to take the EECC test. The objectives of this series are as a review as a general cardiology review and refresher for all physicians. And each session will focus on updates in various core cardiology topics, and also part of preparatory course series for individuals who want to take the EECC test. So my name is Wishnu from Jakarta Heart Center Hospital, Indonesia. And joining me today is Professor Jyh-Ming Juang from National Taiwan University Hospital. He's also a director of Heart Failure Center, a co-director of Genetic Heart Disease, also a founder of Sudden Arrhythmia Death Syndrome Foundation in Taiwan. So he will be the perfect expert to accompany us throughout this presentation. And we have three distinguished speakers today. Dr. Julian from an electrophysiologist from National Heart Center Singapore, Dr. Derek Lee Pok Him, also a heart failure specialist from Queen Elizabeth Hospital, Hong Kong, will bringing the topic of peripheral disease and cardiomyopathies, and Rochelle Regina Cruz from Cardinal Santos Medical Center in the Philippines, and she will bring a topic about CVD in non-cardiac surgery. Some disclaimer and house rules. The content of this webinar is copyrighted by APSC. The views and opinions expressed are those of the faculty members and do not necessarily represent those of the APSC. This webinar is live streamed via APSC Facebook and YouTube pages. CME points will be submitted for those who are connected throughout the whole duration. You will receive your certificate of attendance upon completing a survey and will be sent via email post-webinar. And just to remind our upcoming webinars, it's on 17th of April 2024. It is another APSC-EECC Core Cardiology Review series. And in episode 8, the title will be about preventive cardiology, sports and rehabilitation, and in cardiovascular disease. So make sure you will attend that one too. So without further ado, let's get started. And I would like to invite our first distinguished speaker, Dr. Julian from National Heart Center Singapore. Please, Julian, the time is yours.
Thanks, Vishnu. I'm going to try to share my screen. Can everyone see my screen?
Yes, we can, Julian.
Thank you. So firstly, I'd like to apologize for my lack of video. My video is poor, but greetings from Singapore. So I'm Julian, and I will be sharing a bit more about cardiac channelopathies today. So there are very different differences in cardiac channelopathies, but I think for the interest and purposes of this meeting, I'll focus on the big three: long QT, Brugada, as well as CPVT. So we'll start with the first case. This is a 17-year-old girl who's lay, and she had no past history presenting with symptoms which sounds like vasovagal syncope, and when she was walking to our train station with prodrome and rapid recovery, otherwise was unremarkable. This is the first ECG that we see, focus on the QTC that was measured by the machine and was actually labeled as 484. Second thing to note is actually the ECG pattern of the T waves, and I'll move on to the next ECG. So with this ECG, of course, we will repeat serial ECGs to see if there are any differences or changes that may be dynamic. In this particular case, you can see that the QTC measured here is a bit longer than the previous QTC. So questions. Number one, do you concur with the diagnosis provided by the emergency department, or would you call this long QT? Number two, if you do suspect this girl to have long QT, which phenotype or genotype do you think she belongs to? And thirdly, how do you propose to re-stratify or treat her? So these are the top three questions that I would have in my mind when I first see a patient with suspicion of syncope, and that was very, very young. So to answer that question, so how do we actually measure QTC? I'm sure all of us know we use a tangential method And we usually measure from leads 2 or leads V5 to 6. Although in some instances, we may measure from the T waves that's most prominent in the 12-lead ECG. In terms of measurement, we should have reproducibility and consistency. We should measure consecutive beats and we take the maximum interval. And generally, in some patients, you may see some U waves, as you can see in this diagram, but we do discount that unless it is tall, which by definition is more than 1 millimeters, or fused with the T wave, as you can see in the third example right here, and laser pointer here. What if the TU wave wave is complex? In that situation, what we will do or recommend is to actually aim for the largest TU complex and measure from the end of the T wave. In this case, you can see there's actually a ST segment that is depressed, and we use this because the U waves appears to be largest. On the other hand, as you can see, there's a deep T wave inversion there after the T, and in this situation, you take here and not here instead. So now that we know how to measure in this particular lady, we should confirm the patient's QTC by remeasuring ourselves manually, and we can correct it for the heart rate using the Bazet criteria. In this case, for ease of demonstration, I use the V2 lead, and you can see that the QTC is prolonged at 483 milliseconds. So what is considered as normal and what is considered as abnormal? So there are two different sources of normality usually. One, from large population-based studies reporting distribution of QTC in ostensibly healthy individuals. Or number two, genetic studies for a particular disease, and they report the intervals of individuals who are not genetically affected. So those are the two main sources. So in this study published by Briskin very early on in 2009, we can see several things. Number one, the shape of the QTC distribution in any normal population is a Gaussian distribution. Number two, normal is defined as any value falling within 2 standard deviations from mean, and this varies by population. Number three, we do realize there's a significant overlap between what's considered normal as well as what's considered long or short. So limitations from this population-based data is that number one, these are all derived from computer-generated QTC. And with that, we realize that there's an overestimation when we look at this data. And this is the same. So when you have an ECG that shows a prolonged QTC, you should remeasure it yourself. Number two, some patients who are labeled as normal at the extreme ends may be abnormal, given the lack of genetic testing. So about genetic population, patients with genetic testing, and we look at what's normal and what is long QT. So in this study published in 2001, a long time ago, we can see that in this top upper left corner, there's significant overlap within the range of 420 to all the way to 490 between long QT and what's considered as normal. And therefore, this confirms there's a significant overlap. So if we were to use different cutoffs of these QTCs, the sensitivity and specificity may vary. Number one, if you do not want to miss any long QT patients, then perhaps we can use a QTC cutoff of 430. But in that situation, we tend to overdiagnose 40% of the time. However, if we were to use what we now know as a 450 milliseconds cutoff for males and 460 milliseconds in females, 90% of them will have long QT if they are above these values, whereas about 10% of them are normal. So what if we were to stretch it further, somewhere around 470, 480 for females? And in that situation, can we just say that all these patients are long QT? So I think we need to actually be mindful, especially in patients who are asymptomatic, that maybe there are other causes for this, and we need to think of other differentials. Now, a word of caution when we do these measurements is that Bazet formula is used generally for correction of QTC, and it has issues. It tends to undercorrect when it's fast heart rate and overcorrect when heart rate is slow. So when we see someone having a long QTC with sinus tachycardia, we should always repeat the ECG when the heart rate is lower. Secondly, can we just then say, for patients with QTC within the 400 to 450 milliseconds range, is it safe to exclude? Now, based on all this data thus far, the ratio of likelihood of someone with this range of QTC having long QT is actually very low, and that's 500:1. But if you highly suspect based on history or family history, then you should repeat ECG in these situations. So how do we diagnose long QT then? So this is the criteria based on the guidelines, which is quite dated in 2013. And this is based on several things. Number one is a long QT risk score, also known as a SWOT score. And this is provided that there are no secondary causes for long QT. Number two, if they already have what we call an unequivocally pathogenic long QT mutation, they are also diagnosed as long QT. And in patients with long QT that is persistently more than 500, that is on repeated ECGs, you can call them long QT as well. Now, what if What about in-between cases? And that's probably what we can call them as probable. And this would be the range of 480 to 499 milliseconds when you repeat them, or possible when the short score is actually on the lower end. So what is this short score? So this is a short score that was actually published a while back in 2013. It consists of 3 main groups of criteria: ECG, clinical history, and family history. So as you can see up there, there are some caveats to this scoring system. Points are given. So in number 1, you will always ensure there are no secondary causes. If not, you cannot call them as congenital long QT. Number 2, the QTC is measured by Bassett's formula. So we use Bassett because this is the only one that's used for short score. Number 3, a look at number 3, Torsades-Dubois is actually a mutually exclusive criteria when it comes to ECG, and therefore it is additive on top of QTC. Number 4, what is considered low heart rate is actually based on the second percentile for age, and there may be a graph distribution for this. And lastly, in the family history, you cannot use the same family member who has definite long QT as well as unexpected sudden cardiac death to tabulate this score. So this is the score, and you can see colored in over on the right. Anything that's more than equals 3.5 would be officially diagnosed with long QT syndrome. Anything in between 2 to 3 will be considered as probable, and anything that is below is, you can forget about it. It's probably unlikely long QT. So a lot of these things very confusing, many things out there. So what if you're in a busy clinic? What's a tool to help you? So there's some QTC calculator out there. One such example is this, the Amsterdam UMC, and they have all this numbers that you can crunch in, and they will give you the likelihood of a person having long QT syndrome. Now, beyond long QT measurements alone, I think what's important is that the T wave morphology. So patients with long QT syndromes have very specific T wave morphology, and this is based on a paper that was published in 2000, and they actually investigated 274 gene carriers from 29 long QT families, and they actually could categorize or describe the different types of T wave morphology in long QT1, long QT2, and long QT3. So this is, in long QT1, you can either have an infantile state kind of pattern. What does that mean? Essentially, these are babies in the age of 2 months, 2 years, and they have additional features of infantile ECG, such as very fast heart rate and RV predominance. You can see here, there's an RV train pattern V1. They may have a very ill-defined ST segment that merges with the T wave, as you can see here, and therefore it has a rapid upslope thereafter. So this is what we call infantile. And we know the broad-based one that's very common. It can be normal, especially in adults when you measure the QTC. And in some situations, we can call them late onset normal. So essentially, it's just older age group because they tend to present very young, but in some patients, they may not manifest early. How about long QT2? I think the hallmarks of long QT2 would be the bifid T waves. There are those with very obvious bifid T waves. There are those with very subtle bifid. Either the first T wave is smaller than the second T wave, or the other way around. And lastly, there are those who are just very, very low amplitude. Lastly, we have long QT3. They are usually late peak. They can be biphasic, or they can be asymmetric peak. So these are the most common kind of ECG description of T waves that you will see. In this paper as well, we'll look at the distribution of some criteria. So in long QT1, as mentioned, they tend to be normal. In patients with long QT2, they have a higher propensity to be bifid. And in patients with long QT3, you realize that they have a very long ST segment duration. So those are the things that are quite important to take note of. So back to our case. This patient has this ECG, and if we were to actually look carefully at V4 to V6, there are subtle bifid waves, where the first bifid is taller than the second bifid. Number 2, when we suspect someone to have long QT, we should always ask a complete family history. So as you can see, this is a genogram of this patient's case. Square are males, circles are females, and the index case are the one with arrow and the age here. And X equals to death. As you can see, there's a significant family history of death with use of ICD. So the sudden death here, in terms of the patient's aunt and patient's mother, is actually officially diagnosed with long QT and followed with another hospital. So what does that mean for our patient then? So in this case, this patient has a short score of 5, and it's a definite long QT syndrome that we can officially diagnose for her. So how did we manage her? So we diagnosed her as symptomatic long QT. We did refer her for treadmill ECG, which I'll talk about more later. We started her on a non-selective beta blockers, nadolol, based on body weight, and we counseled the patient's mother and the patient on long QT precautions. Particularly important in her case will be auditory stimuli. and refer for genetic testing. Now, what is long QT? In brief, we have many different genes out there. They tend to have a female preponderance with a prevalence of 1:2000, first described in 1957. A majority of them is due to loss of function, variance in voltage-gated K channels. The only difference is that in patients with long QT3 is a gain of function mutation, and it's due to prolongation of action potential resulting in early after depolarization, leading to torsades du pont. This is just a summary table which I'll leave here. Now, the question that I want to ask is there a role for provocative tests? In the guidelines in 2013, it puts that as may be considered in uncertain cases. Following up that, in the 27 ACC-AHA guidelines, in class 2A, only for standing and exercise treadmill provocative tests. On the other hand, routine diagnostic testing with epinephrine challenge has been ruled out in the 2022 ESC guidelines. So where does this recommendation data come from? So in 2011, the Ackerman team Mayo Clinic did publish this paper, which I think is quite important, and it looked at the distribution of QTC in controls as well as patients with long QT. And the reason for this is because we now know that a significant portion of patients with long QT actually have non-diagnostic QTC at rest, and that's about half, 40% of them. So in this paper, what's very stark is that you look at the black box plot diagram, and this refers to patients with long QT1. On the left here is the long QT1 of the whole cohort. On the right is those with concealed long QT, meaning they present with normal ECG, QTC values, and then they have repeated ECGs which show that they actually have long QT syndrome. And I think the main thing is to say that these patients have these findings. Number one, we can unmask patients, especially with concealed long QT1. Number two, there are some values that they use to kind of discriminate long QT1s from all subset. And this is with an absolute QTC value of more than 460 milliseconds. And the principle behind this is when the heart rate increases, generally QTC shortens as well. But in patients with long QT syndrome, they tend to have a very abnormal repolarization behavior, and they tend to have either QTC prolongation or transient shortening before elongation again. Number two, there's also this thing called delta QTC, where they measure delta QTC at recovery, and it minus it with baseline, and if it's more than 30 milliseconds, it has a good specificity and sensitivity to rule out long QT1. What's more important is that the use of beta blockers do not blunt these maladaptive responses. Now, what the caution is that, number one, there's no randomized data to date. Number two, these are mostly single-center studies, and they are using multiple different protocols. So there are 4 different protocols that you can use for this, as I've listed here. And the third thing is that there are very inconsistent cutoff points from all studies. Just some example, on the left, this is a normal patient. At rest, QTC is already normal, and as the patient exercises further, QTC tends to shorten even during recovery. On the other hand, in the patient with concealed long QT, they present with normal QT, and when they exercise, the QT actually extends. And even during recovery, these maladaptive responses tend to kind of continue later on. In the patient with, on the right hand, you have this patient with long QT, where initially there is a shortening of QTC, which then subsequently elongate during recovery. So this is also an example of a patient with maladaptive response. So our patient, at baseline, she now presents with a very prolonged QTC of 510 milliseconds, further confirming our suspicion that she has long QT. We did further treadmill exercises and recovery. Suffice to say that during the exercise, we can see the QC lengthened further to 600 milliseconds. And this is just a tabulated response over the QTC. And you can see that it lengthened further during recovery, further confirming this patient has long QT. Now, the second thing I did mention earlier is a postural QTC change. And the reason behind this is similarly, when you have a transient sudden change in posture, there is usually a heart rate acceleration. But what happens as well is generally in normal patients, QTC should also shorten. But this response is actually not instantaneous. So if you do this sudden change in posture, you may suddenly see a sudden sinus tachycardia, and the QTC prolongation may suddenly be more marked in patients with long QT. And this is a protocol that was actually published by Viskin in 2010 in JACC paper. So this is the box plot diagram for all that they did, just to summarize everything. In what they found is this, that when a patient that is normal or long QT, when they stand up, both of them will also have similarly heart rate would be faster. This is the appropriate response, but the QT interval will differ in terms of response to tachycardia, where controls have shortening and long QT patients increase. But the issue is that because the R interval shortened more than the QT, so in patients during maximal tachycardia, you realize that both long controls and long QT will still have a prolongation of QTC during this change. But there is some cutoff in terms of this value, and they found that this postural change in QTC test was particularly impaired in patients with long QT. Another word of caution is thus far there is no recommended cutoff for QTC at specific time point. So this is an example of that. One such example of this phenomenon is what called QTC maximal stretching. When you see that the heart rate increases, what happens is that the RR will shorten and the PP will also shorten as well, but the QTC doesn't shorten as much. And what you realize is the T waves start to creep onto the subsequent P wave, and therefore in the patients with maximal or shortest T to P, that's when you measure the QTC and you realize that they actually have prolonged QTC in that session, at that mark as well. This is another example of patient with long QT, similarly with prolongation of the patient's QTC at maximal tachycardia. So what about genetic testing? So genetic testing, we know that there are multiple genes that are associated with long QT, but most are of limited and disputed evidence, with only 7 that are of definitive and causative to cause long QT. They are all given class 1 for diagnostic as well as therapeutic indications when patients with long QT, so you should do gene testing. So these are the genes proposed in the guidelines in 2022. Essentially, if you have high probability, this is what you should consider. On the other hand, this is a class 2A. If they have associated features such as deafness, you can consider Jervell-Lange-Nielsen syndrome. If they have red feet, what we call acute syndactyly, you should also consider CACNEC1. We have the Trident-KO syndrome, as well as Anderson-Tawil syndrome as well. So Anderson-Tawil is actually characterized by periodic paralysis, cardiac abnormalities, and dysmorphic features, and they are autosomal dominant. So the main focus of today's talk will not be to talk about management of long QTC, and most important is for you to identify as well as refer appropriately to the relevant people and re-stratify them. But suffice to say that you can divide them according to their symptoms, if they're asymptomatic or they have extreme presentation of cardiac arrest. And in this particular situation, you know that green is class 1, beta blockers, usually we prefer non-selective beta blockers, Nadolol. And in patients with long QT3, we consider Maxillotin in some of these patients. And beyond that, if they have aborted cardiac arrest, we consider ICD. But on the other hand, if they're asymptomatic, we look for other high-risk features such as syncope. And if they have recurrent VAs, then we may need to consider additional adjunctive measures such as sympathectomy and concomitant ICD as well. So there are also other risk prediction algorithms out there. This was actually given a class 2B recommendation in the ESC guidelines. It's based from the University of Pavia in the 1, 2, 3 long QT syndrome, and it's only using 2 variables, and they use a cutoff of 5% at 5 years for sudden cardiac death as the most balanced threshold for ICD intervention with those who are in between. And most recently, the Mayo Clinic as well has come up with another algorithm. University of Rochester has also come up with another algorithm which added additional 4 parameters, and this is based on beyond that age, gender, as well as history of syncope and use of beta blockers. So we are done with long QT. We move to case number 2, essentially with a young male who has significant history of query seizures for 1 episode at the age of 19 years old, followed by nocturnal enuresis for 2 to 3 months upon starting military training. He was seen by neurology, which was cleared for epilepsy, and he actually was seen by the pre-enlistment screening team, of which he was told his ECMO ECG is normal. He had a significant family history where the uncle recently, during this year, had underwent flag night challenge and developed VF during the flag night challenge, and her paternal grandfather demised at the age of 26 years old in an event called the mort d'amor, what we call death during intercourse at 1960s with no autopsy. So it's now referred to screen for Buerger syndrome. So this is his ECG in your clinic. Questions to ask is, number 1, is the ECG, clinical history in ECG alone diagnostic of Buerger? Can we do anything else in clinic? Number 2, when do we do provocative tests with class 1? Number 3, if it elicits a type 1 Buerger pattern, what should we do next? And lastly, is there a relevance to the history of nocturnal enuresis and suspicional epilepsy? So we know very well that in patients with Buerger syndrome, we should always repeat ECGs at high intercostal space, at second and third intercostal space, because we know that the pattern is sporadic, fluctuating, and under the influence of many factors. We have the common type 1, as you can see here, where the atypical right bundle, the right FT segment is taller with this rectilinear downsloping and a negative T wave in A. We have what we used to know as type 2 and type 3, which has kind of fallen out of favor in terms of being recognized as a significant ECG pattern. In this case, we had a 1 intercostal space up and 2 intercostal space up, which is none the wiser. So when do we consider provocation testing? Number one, know that the origin or the kind of evidence dates back in 1996, back in Japan, when they used the class 1A antiarrhythmics. Currently, right now, there are 4 drugs commonly used. Class 1A, as you can see there, and class 1C, and this is dependent on your geographical location, and they all act on sodium channel, voltage-stated sodium channel, particularly that of 1.5, and they actually inhibit sodium current. So how do we do sodium channel block testing? Essentially, you need to be in a proper place that is capable of monitoring as well as advanced cardiac life support. There's standardized lead positions at V1, 2, and you repeat the ECGs before and during and after. And this is actually taken from the guidelines in 2022, but on our end, what we do recommend is that doing 2 minutes for the first 20 minutes and subsequently repeating at 30 minutes, 1 hour, 2 hour, and 4 hour mark. These are the doses, and we terminate the test if it either induce type 1, we have significant ventricular arrhythmias, or when QRS widening more than 30% compared to baseline, or in patients with hypotension. So is it the same or to do sodium channel blockade or provocative tests with class 1A, class 1C? And the answer is no. And it's because of the mechanism of the sodium channel inhibition. 1A acts on the activated state, whereas 1C acts on the inactivated state. And there's a differences in degree of all these various factors. And some of these medications do have additional supplemental effects on the potassium current state, and as well as the calcium release. Based on studies, edgemelin is most potent, whereas procainamide is the least. Of course, using edgemelin, there are some concerns with accuracy because there are some causes of false positive tests with edgemelin testing. In this patient, at a 10-mark second night challenge, we see a significant Brugada pattern in V2, and therefore, this patient was diagnosed with Brugada syndrome. Now, we know that there's a male preponderance, 80 to 90%. Asia tends to have the highest prevalence. Their manifestation is predominantly nocturnal. They are usually asymptomatic, but sometimes they have syncope or cardiac arrest. I think most notably in Thais would know, in the northern Thailand, there's this phenomenon where it is described by the cultural folklore as Lai Thai, where young, healthy males tend to pass away in sleep. 28% of sudden cardiac deaths, they account for 20% of sudden cardiac death in patients with apparent normal heart, and they also account for 5 to 10% of resuscitated cardiac arrest. The second thing to talk about is the concept of Brugada burden. So as I mentioned earlier, there are changes in ECG features that varies with time, as well as how you place the ECGs. Now, Viskin popularized this idea of Brugada burden in patients with peripheral Brugada pattern, where they feel that these patients, they tend to be at a higher risk of sudden cardiac death. So meaning to say that they have this pattern of atypical right bundle in other leads. There are also other depolarization abnormalities or repolarization abnormalities that also portends higher risk of sudden cardiac arrest. AF is known as a marker of poor prognosis, and in some situations, sudden cardiac sinus node dysfunction as well. So these are some examples of what we call AVR sign, which is a marker of SCA, early repolarization pattern, particularly in inferior lateral leads, as well as QRS fragmentation described as more than 4 spikes in V1 or more than equals 8 spikes in V1 to 3 in totality. Genetic testing is recommended, but it's only useful for family screening. It does not help in management of the patient, and there's only 50% penetrance, and the only gene that is recommended is SCN5A. Because of these reasons, you do not use genetic testing to screen for Brugada syndrome. If they are adults and they have a family history of Brugada syndrome, the one-time ECG screening as well as sodium channel blockade provocative test is sufficient. But if a pediatric patient, you start monitoring ECG serially every 3 years until 15 years of age. And subsequently, you can consider sodium channel blockade provocative testing. And the reason being is that we know we shouldn't use flecainide edgemelin in young patients due to high risk of adverse events. Arrhythmogenesis, generally speaking, as mentioned earlier, voltage-gated sodium channel issues, and it results in 2 things. Number 1, reduction in peak sodium current, and therefore it results in a delayed upstroke, as you can see in phase 0. Secondly, there's also differences in hypothesis, whether you are believer of depolarization or repolarization hypothesis, either an RVOT conduction delay or an increased outward K current resulting in phase 2 re-entry. This usually results in shortly coupled PVCs at night, and then they degenerate into VF. So how do you diagnose Brugada is listed here. If you have more than or equals to 1 lead with that morphology in V1, 2 at the various intercostal space, provocative tests can shed some light. I think the most important thing is that with provocative tests, we are concerned about overdiagnosis. And so we have the Shanghai score, which was actually published in 2016, similar to the Schwartz score. It actually looks at a few things: ECG findings, clinical history, and family history. These are the caveats, and we use the highest score in each category. Anything more than equals 3.5 is diagnostic of Brugada syndrome. Anything in between is considered possible, and anything less than that is unlikely. So why do we have this? And this is based on the data here. And this is a distribution of all patients according to the score in Japan from 1996 to 2016 of 393 patients. So a summary of this is this. When they look and they see there's an increase in the Shanghai score, there is an increase in VTVF events. And the pivot point seems to be at 3.5. With anyone less than 3.5, there are no malignant events. And 50% of the cohort is actually less than this cutoff. So this suggests that the cutoff is appropriate for diagnosis. In terms of the incidence, this is the incidence based on the score itself over 10 years. And they found that the predictor of poor prognosis was as mentioned earlier. So how do you counsel patients with Brugada syndrome? You counsel them on the sudden cardiac death risk. If it's spontaneous, the risk is higher. If they have symptoms, it is higher as well. And this is based on the 4 different papers here. And this is the sudden cardiac arrhythmic risk. And this is actually if they're asymptomatic, drug-induced spontaneous as well as symptomatic. What about trigger avoidance? They should avoid fever as much as possible to control the fever with rapid sponging as well as Panadol as well as NSAIDs. Avoid certain drugs as well as either prescription or illicit, and avoid alcohol intoxication. For more information on that, we know this very well. There's a website where the patients refer to, www.brugada.org. In our particular case, the Shanghai score for this patient is relatively high, is 6. So therefore, this is a patient with Brugada syndrome. So what do we do next? She has a remote history of suspected arrhythmic syndrome. Do we implant ICD? Do we do a VTVF study? Do we do loop record, or do we just observe? Now, the thing about this VTVF study is that it was proposed by the Brugada brothers as some form of re-stratification based on their study. But unfortunately, we have not been able to corroborate their findings in the larger finger and prelude registry. And the current data right now is actually conflicting. So there are some concerns about reproducibility. So the patient couldn't accept ICD. He underwent a ventricular VTVF study and is negative, and he declined the recorder. So he's monitored and so far it's negative. In terms of management, I think I'll just skip here. And I'll also skip the management of electrical storm because your EP physician should be involved. I just want to highlight the idea of Brugada phenocopy, which was popularized by several people. Essentially speaking, they look like Brugada, but they are not Brugada. And that's because it's dependent on clinical circumstances. You have a type 1 pattern mimicus and type 2, as I listed here, and I will not go further. With regards to the last slides of Brugada, I would say that there's a link between nocturnal enuresis, particularly secondary nocturnal enuresis, and that's because when they have seizures or VTVF episodes, they may lose their body tone and may get evidence of this nocturnal enuresis. And there are some co-expression of mutations for epilepsy as well. So I think my time is actually up. I have a third case, but I think I would skip this because in the interest of time, and I will just pass the time back to the speaker, to Wishnu. Thank you very much.
Thank you, Julian. That's a very in-depth and comprehensive presentation. So I don't think we have enough time for further comprehensive discussion, so I will just ask Professor Jyh-Ming Juang to please have your insights. Welcome, Professor Jyh-Ming. Great to have you here.
Welcome. Sorry for the internet problem. We just tested last week. It was fine, but I don't know what happened today. Sorry about that.
Professor Juang is also an expert in electrophysiology. Also, is the founder of Sudden Arrhythmia Death Syndrome Foundation in Taiwan. So probably you want to give us some insights on this, especially on long QT syndrome and Brugada syndrome, Professor Jyh-Ming.
Yeah, I think the the Dr. Julian Tai is has very good presentation regarding the long QT and the Brugada syndrome. The overview focus on the general idea and how to diagnose the patient with the risk of sudden cardiac death. I think this presentation is very good. And one thing we can consider is what's a red flag we should consider to work up for young patient who has syncope. So if a patient with sudden cardiac death, all cardiologists will be very alert. It's, oh, well, this is young people have died suddenly. We have to work up for the etiology of ventricular fibrillations. So we will consider long QT Brugada syndrome, especially Brugada syndrome, I think so, because this is more endemic in South Asia, in our areas. More common. My data shows it's around 1/1,000 patients. The nationwide study in Taiwan. So it's probably 7 to 8 times higher than that in Europe, even higher than the US. So all we are doctors in the Asia, especially South Asia, we should be more aware about the Brugada syndrome when we dealing with the patient with the unexplained sudden death in young men. So especially young people younger than 40 years old, from 20 to 40, there will be high peak area, even the 50. And very interesting, we found a very interesting case this year. The youngest one is 6 months. 6 months baby. And he was resisted by the babysitter. And we did a Jyh-Ming test. A Jyh-Ming test is very powerful, but should be used cautiously to unmask the Brugada syndrome. So our hospital is the only one hospital which has the Jyh-Ming in Taipei, in Taiwan, National University. So I would encourage and recommend that all cardiologists in each medical center in Asia to, I don't know how many hospital or some maybe other speaker or moderator can give some comments, which your hospital is available to have a Jyh-Ming in your clinical practice.
Thanks a lot for Juang. So we'll due to time issue, we will move on to our second presentation. And for all participants that are listening to this series, just remember that you can drop a question anytime by putting in a Q&A session. So for the next speaker, I would love to welcome our second speaker, Dr. Derek Lee Pok Him from Queen Elizabeth Hospital, Hong Kong. Please, Derek, time is yours.
Okay, is the slides and sound all good?
All good, Derek.
Okay, right. Thanks for having me. Let me check my video. I think my video is blocked. But anyway, thanks for having me tonight. I'm Derek Lee from Queen Elizabeth Hospital, Hong Kong. I'm assigned to talk about pericardial diseases and cardiomyopathies. And technically, this consists of 15 to 20% of cardiology. The only issue is I only have 15 minutes for this talk. The ESC guideline outlined 4 cardinal features of acute pericarditis, namely the typical chest pain, the rub, the ECG, and the effusion. You don't necessarily get all of them, but if you get 2 of them, you can make the diagnosis. Of course, you can consider additional testing such as the labs and the imaging to support your diagnosis. And most acute pericarditis are idiopathic with a duration of less than 3 months. The treatment of acute pericarditis consists of 2 weeks of aspirin or NSAIDs, but please do not forget your colchicine. The use of steroids in general is discouraged due to an increased risk of recurrent pericarditis. And the guideline also suggested avoidance of exercise, but no one really knows where it comes from. Pericarditis with increased troponin or reduced ejection fraction technically refers to myopericarditis. In these cases, ACS should be excluded. MRI, if available, should be considered to confirm the presence of myocarditis. These patients should be hospitalized and monitored, and they should be treated with aspirin or NSAIDs. And in general, these patients have good prognosis. The main problem is recurrent pericarditis, which constitutes 15 to 50% of all pericarditis cases. It is commonly associated with autoimmune disease and steroid use. And same as acute pericarditis, you treat these patients with NSAIDs for up to weeks to months, and colchicine of at least 6 months. The ESC guideline also outlined a list of second-line medical treatment and pericardiectomy in selected refractory cases. Constrictive pericarditis. It is more common in exams than it is in real life, probably because of these classical physical signs. Rapid wide descent, because early diastole is the only time the ventricles get filled. Kutzmal sign, instead of jugular vein collapse during inspiration, it expands. Pericardial knob, honestly, I haven't heard of it before. Pericardial calcification can be seen all around the heart, but most commonly, look for the inferior wall. So if you see patients with recurrent, unexplained heart failure with normal ejection fraction, do think about the possibility of constrictive pericarditis. I think this is the most important slide about pericarditis, constrictive pericarditis. Now imagine, within an eggshell, the egg white and the egg yolk were in the same compartment, so they share the same pressures. Now the egg yolk built a wall around himself, so there is a dissociation between intrathoracic and intracardiac pressures. And the intrathoracic pressure is reflected by the wedge pressure, and the intracardiac pressure is reflected by the LV pressure. Normally, they go up and down together during respiratory cycle and maintain a constant gradient to drive blood into ventricles. But now with the dissociation of pressures, the pressure gradient becomes variable, with better LV filling during expiration and poor filling during inspiration. This can also be measured in echo with pulmonary vein Doppler and mitral inflow, with a smaller magnitude during inspiration and larger magnitude during expiration. The second cardinal feature is ventricular interdependence. As the right-sided filling increases during inspiration, it causes the septal shift to the left side, compromising the left-sided filling, and vice versa during expiration. Lastly, restrictive filling. The deceleration time will be short, high E velocity, and rapid drop in velocity because there is equalization of pressure or even inversion of pressures that stops the flow forward. Such abrupt halting of ventricular filling corresponds to the square root sign on invasive hemodynamics, as the stiff pericardium limits ventricular expansion. So which echo features can distinguish constrictive pericarditis from restrictive cardiomyopathy? LA enlargement, restrictive filling pattern, annulus paradoxus, or severely dilated IVC. Remember, only annulus paradoxus here can distinguish between the two, and a medial velocity of 8 centimeters per second or more in patients with heart failure with normal ejection fraction suggests constrictive pericarditis. And the Mayo Clinic developed an echo criteria for the diagnosis of constrictive pericarditis with a pretty decent sensitivity and specificity. I want to especially highlight this hepatic vein diastolic flow reversal with expiration. This is not due to atrial contraction. If you look at the timing, this is before atrial contraction. All chambers are relaxed at this date. The reason for the reversal is because of the septal shift. If you catch this reversal before atrial contraction, it is an excellent sign for constrictive pericarditis. Definitive treatment is always tough to counsel patients for complete pericardiectomy because of 6% 30-day mortality 80% survival at 5 years, and 60% survival at 10 years. Constrictive pericarditis can occur after cardiac surgery in 2 to 5% and can be challenging to diagnose. But keep this diagnosis in mind when you see patients presenting with unexplained biventricular failure with normal ejection fraction. Do consider invasive heart cath and imaging. And medical treatment with NSAID and colchicine may resolve the transient constriction until the resolution of pericarditis. Cardiomyopathy. In the 1980s, WHO defined cardiomyopathy as heart muscle disease of unknown cause. And the essence of the definition has not changed now. This is the definition from 2014 guideline, a myocardial disorder in which the heart muscle is structurally and functionally abnormal in the absence of coronary artery disease, hypertension, valvular disease, and congenital heart. It doesn't mean that you cannot have these conditions, but it means that if you have a dilated left ventricle 7 centimeters and a stenosis in the OM branch 50%, that is not accountable. All cardiomyopathies are either genetic or acquired, but now we know the majority is genetic. The phenotypes can be variable, mild to severe. The expression of genes can also be variable, which means that you are born with the mutation and it does not manifest itself until teens, 20s, 40s, 50s, or even later. And if we are dealing with a genetic disease, it is not an individual issue, but a family issue. What comes along with it are issues regarding transmission within the family, guilt if you're a parent with kids, employability, certain jobs, certain sports you cannot play anymore, insurance. And this is an important slide. All cardiomyopathy patients come to you in one of these ways. Either they had aborted sudden cardiac death, sudden cardiac arrest, and hopefully not sudden cardiac death. Or they present to you with heart failure symptoms, or atrial arrhythmias, or worse still, a stroke. You've all seen this. It can be thick, it can be baggy, it can be twitchy, it can be rigid. You can describe it in more sophisticated way, apical, midband, reverse curvature, hypokinetic, non-dilated. But the thing is, these are morphologies, they are not diagnoses. You can describe it in whatever artistic ways you can, but ultimately, you need to know the etiologies and what issues they cause to the heart. They can be either genetic or non-genetic. As mentioned, majority of them are genetic. And if you like a long list of diagnoses, here you are. Histories and physical exams, though boring, but do not forget these. If you are 10 years old and thick heart, you don't have amyloidosis versus a 75-year-old gentleman with thick heart, especially with HFpEF, you could well have amyloid. Someone comes in with waddling gait and dilated cardiomyopathy, this can be muscular dystrophy. And deafness is also important. If you see young person, thick heart, diabetes, deafness, you need to think mitochondrial. And family history in a rush clinic is very difficult, but don't skip it. Some important ECG patterns in cardiomyopathy, some are well recognized, for example, that of Fabry's, amyloids, apical HCM. But AV block is an important clue in cardiomyopathy that points us down a list of diagnoses, which can be genetic or acquired. And among the acquired causes, for example, in dilated cardiomyopathy, most commonly is inflammatory myocarditis. Genetics are critical and interesting. They are diagnostically, prognostically, and therapeutically useful. There could be overlapping of phenotypes with certain cardiomyopathy genes. But it's important to know not only the genes being affected, but the exact genomic locations. Sometimes you see variants that tend to cluster around certain protein domains and affect certain parts of the sarcomeric protein structure. In our recent HCM variant analysis, for example, all of our MYH7 variants clustered around the S1 domain corresponding to the head and neck region of myosin heavy chain. And sometimes we find mutation hotspots in our population. That means unrelated individuals having the same exact variants, hitting the exact same amino axis with the same mutation consequence. And such variant can be quite predictable of poor clinical outcomes sometimes. And not all variants in sarcomeric genes are pathogenic. For example, in our MYPPC3 cohort, all pathogenic variants are truncating variants, which are well known to cause disease. But there are also MYPPC3 variants that are too common in our population to cause disease. They are likely to be more benign. We have lots of VUS today, variants of unknown significance. Don't just dismiss them casually as if they were all benign variants. Many of them are not. If you look after these patients, you need to have the clinical sense and skills to differentiate which one is hot VUS, that means more likely to be pathogenic, and which one is cold, likely to be benign. MRI is mandatory for every cardiomyopathy cases. I love reading the MRI images of cardiomyopathy patients. By looking at the LGE and parametric mapping, it draws us to a list of specific diagnoses. It gives us functional data and tissue characterization, which helps you in risk stratification and prognostication. They also identify features which you don't often see with routine echo. And MRI identifies patients with ultra-high arrhythmic risks. And then based on what we know about the morphologies, the etiologies, and what it does to the heart, we develop a phenotype-guided management strategy. Whatever types of cardiomyopathies, the concept is the same. If it makes your heart twitchy, target the channels or find the foci. If it causes atriopathy and atrial fibrillation, rhythm control if possible, and anticoagulate them. In hypertrophic cardiomyopathy, look for outflow tract obstruction and make sure you sweep across the mitral valve to the outflow tract and you don't mix up the MR signal with the outflow tract signal. Make sure you look at the papillary muscles and chordal attachments because they can cause obstruction themselves. And make sure you don't skip the provocable maneuver and you know how to do a good Valsalva. If you don't, nowadays there are gadgets to help you do it. Just ask the patient to blow into the manometer. Sudden death risk assessment is critical in cardiomyopathy, but we are still doing a bad job. Some ICDs never fire. Some ICDs only fire by mistakes, while some passed away one day on the street without an indicated ICD. We're still terrible in predicting risk, and on the other hand, judging what is acceptable risk and what's not. We all use this HCM risk score. Let's say 5% in 5 years. What does that mean to you? It might be low for you, but it could be high for me. In dilated cardiomyopathy in the past, the indication for ICD is primarily based on ejection fraction, but it's a sloppy measurement. And number two, most of the sudden cardiac death cases do not occur in EF less than 35. Then I have my old patient in 60. His father died suddenly at 55, multiple short runs of non-sustained VT and HOTA, heart failure symptoms with a mid-range ejection fraction, peculiar scars on MRI at epicardial and septal, but still the ejection fraction is not bad enough to get an ICD. Later, he presented with out-of-hospital cardiac arrest near a swimming pool and was luckily rescued. Fortunately, the latest guideline paid attention to the loophole and gives us additional ground to consider ICD with genetic study and MRI features. In our patient, he had a pathogenic vitamin C variant. And I believe genetics and MRI are going to play a big part in SCD risk assessment. We haven't got enough time to go into the exciting era of new therapies that are available, such as mavacamten, and those that are on the horizon, such as the Cure Heart project led by Professor Hugh Watkins from Oxford and Jonathan Seidman, Christine Seidman from Harvard. But certainly we are seeing new therapies that can effectively target the molecular and genetic pathways of cardiomyopathies. And certainly we are aiming to cure these diseases. Again, we don't have time to go into each and specific cardiomyopathies like Anderson-Fabry disease and cardiac amyloidosis. I'll just leave these figures here for your quick reference during your studies. I honestly don't know why I put this up. Perhaps if you don't get much from these 15 minutes talk, you know who to go to. And this is my last slide. Thank you very much.
Thanks a lot, Derek. That's a very nice, insightful, and updated presentation. And thanks for putting our patients up in the last slide. So this is a very interesting topic because you cover from the basic of pericardial diseases and up to the cardiomyopathies and go down to the cardiogenetics and also the treatment that's targeted on the cardiac genes. So Derek, how do you see the future on this topic of cardiomyopathy and the therapy? Do you really think this is the future?
Now we've known, take hypertrophic cardiomyopathy as an example. We know its name since 1957. So it's been almost 70 years. There hasn't been one single drug to treat hypertrophic cardiomyopathy. But in the late 2010, we have our first drug and lots of new investigational drugs are on the line, on the horizon, especially with the Cure Heart project I've just mentioned. We target exactly at the gene, the very origin of the disease. So these cardiomyopathy field is getting much more exciting, I think, in this era, particularly with more available genetic testing, more knowledge in genetics. I think it is very rapidly evolving, very exciting with new therapies on the line. I'm very positive in the future, and I do welcome, colleagues who are interested in this field. We can work together on different projects around this topic.
That's great. We can easily make, well, not easily, but we can make a collaboration in the Asia Pacific region for this kind of project. So Professor Juang, how do you see this topic about for sudden cardiac death syndrome? You have channelopathies, cardiomyopathies, and what's your view on both sides, actually, both channelopathies and cardiomyopathies?
Regarding so Dr. sorry, a little bit come on cold. I mean, first I say Derek has a good presentation. So your question is about regarding genetic testing or about my opinion about channelopathy and cardiomyopathy?
Yes, that's right.
Okay. I think because the new technology, as you know, the next generation sequencing, you guys know about NGS. So the price of the NGS is going down very, very much. Yeah, so now so probably 5 or 6 years ago, some commercial lab do the panel gene screening. But now go on because the whole exome sequencing, the price is going down. So now more and more patients are doing the whole exome sequencing in our center in Taiwan, and the price go down to less than $1,000, probably go down to 80, even cheaper in the US. So I think what we all cardiologists are facing a challenge. We in my clinic, I got a lot of some report from commercial lab. They come to you and ask for interpretations. So, but we are facing a very big change because, as you know, all cardiology training does not include the genetic testing. Even I think in Taiwan, it's quite a new field. It's called genetic cardiologist. That's a new term. So we need to keep up with follow some ACMG guidelines. You know ACMG, but ACMG guidelines it is very broad. It's not only it's not very specific focus on cardiologists. So as Derek mentioned about that, when we're dealing with some VUS, it's quite very challenging. But the phenotype is very important. So when we interpret the general result, always remember phenotype is king, genotype is queen. That's very important. So when we're dealing with VUS, but sometimes if we still have some ambiguous results, what guideline recommend, as per consensus recommend and as guideline recommend for VUS, we just ask the patient to follow up because some phenotype may come out later, but we don't know. Or waiting for some database updating like ClinVar, ClinGene, some database, they are still building up it, and some new algorithms are coming out year by year. So some VUS will be downgraded or be promoted. So you have to reanalyze the genetic result periodically. So no matter is a channelopathy or cardiomyopathy. So same thing.
Professor Juang, do you have any tips for us, general cardiologists in the region of Asia Pacific, on facing this sudden cardiac death syndrome, either channelopathies of cardiomyopathy? What should we do? What should we keep our eyes on? How we should prepare ourselves to new coming modalities like this cardiogenetics?
It's a saying that
for the most of cardiologists in the region.
Most regular?
Yes, the regular.
For our Taiwan?
Oh no, for general cardiologists in the region of Asia Pacific on facing this sudden cardiac death syndrome.
Channelopathy or cardiomyopathy?
Both, everything.
We do not have the data to do that, but my cohort is called SAS Taiwan. We have given the cohort for 20 years. And more at around 60% are channelopathy. Because I think Bugada syndrome contribute a lot to my cohort, and 40% are cardiomyopathy. Yeah, as you see, the prognosis in hypertrophic cardiomyopathy, which is the most common cardiomyopathy category, right? The 80%, 90% of the patient with hypertrophic cardiomyopathy has very good prognosis under the contemporary treatment. So, but channelopathy, no, because we still see a lot of idiopathic VF, a lot something we don't know, and more prevalent Bugada syndrome in South Asia. So that's my observation in my cohort sets in Taiwan.
Thanks a lot. That's a very useful statistic. Okay, without further ado, so let's move on to our third speaker, Rochelle Cruz from the Philippines, and he will bring the topic of CVD and non-cardiac surgery. So please, Ruchi, the time is yours.
Okay, thank you, Wishnu. It's very hard to follow those great lectures by our very good-looking speakers. I'll try my best. I am Dr. Cruz, and I am assigned to discuss cardiovascular disease in non-cardiac surgery. And this lecture is mainly based on the most current 2022 European Society of Cardiology guidelines. It's an update on the previous guidelines that was published way back 2014. So it's 8 years in the making. So it's a 99-page document. And in the next 15 minutes, I will try my best to give you the gist and condense it as concisely as I can. So just a quick disclaimer, the topics are chosen to best prepare you for the upcoming EECC examination as guided by the APSC Organizing Committee. So I apologize, I cannot really discuss the entire thing. So I'll just leave it to you to read the rest of the document. Now, just a quick background on the issue at hand. So as of 2012, the annual volume of major surgeries is already around 300 million patients per year. So that's about 5% of the world population. And majority of this would be non-cardiac surgeries, or 85%. And soon enough, our elderly patients, or those who are aged 75 years or older, will undergo surgery per year. So that's 1/5 of them. And these are the population that is at most risk for perioperative complications. Hence, these updated guidelines is much needed. So with that, let us proceed to a sample case so that you would relate to the guidelines better. So we have a 70-year-old female with coronary artery disease, diabetic, hypertensive, and a 20-pack-year smoker. So she came in because of pain on the right groin radiating to the right knee for the past 5 months, which is increasing in severity. So the orthopedic surgeon saw her and scheduled her for an elective arthroplasty or a hip replacement. So for further history, the functional capacity is still actually good because she still works as a florista, even if she's 70 years old already. And her work demanded her to bend, walk, and go up and down the stairs. And she's confident that she can climb 2 flights of stairs at a normal pace. So she denies any cardiac symptoms, and she already has basic lab works such as a normal HbA1c, hemoglobin, creatinine, and a normal ECG. So would you require any further testing? Now, cardiovascular morbidity and mortality in patients that are about to undergo a non-cardiac surgery or NCS are determined by 2 main things. First one would be patient-related risk. So it's very important that at initial assessment, we should evaluate the patients with special emphasis on the cardiovascular risk factors, on the cardiovascular disease, and of course, the other comorbidities. The other factor would be surgery-related risk, and this includes the type of surgery, the urgency, and also the experience of the institution that is about to do this actual surgery. And so the cardiovascular morbidity and mortality in patients can be actually reduced if we do an adequate preoperative evaluation and to do proper selection of the type and timing of the surgical procedure. So having said that, shown here is the surgical risk estimate of procedures. So it's a broad approximation of the 30-day risk of cardiovascular death, myocardial infarction, and stroke. But take note, it only takes into account the specific surgical intervention without considering the patient's comorbidities. So as you could see, low surgical risk procedures would have less than 1% of said risk. Intermediate surgical risk is 1 to 5%, and high surgical risk procedures would be more than 10%. Now, for our patient, since she will undergo a hip surgery, then her surgery would be an intermediate surgical risk that we expect that there's around 1 to 5% potential 30-day risk of cardiovascular death, MI, and stroke. Then the degree of urgency should also be considered because in general, acute procedures carry a higher risk of complications compared to elective or planned procedures. So in the guidelines, they use this timing definition. So it would depend on the urgency of the surgery to save a life, a limb, or organ function, and the possibility of developing complications. So of course, immediate surgeries, you have to do it within minutes, or else the patient may die. Urgent surgeries within hours, and time-sensitive surgery, it would depend on a multidisciplinary evaluation on if there will be losing a limb or organ function or complications. Now, fortunately, our patient is scheduled for an elective surgery, meaning it can be performed as planned without significant risk of losing limb or organ function, or increased risk of complications. Now, this is from the guidelines. This is the algorithm. And the first step in managing patients before non-cardiac surgery is to determine the urgency of the procedure. Now, for emergent or urgent procedure, it would limit our time for evaluation since it should be done without delay as mentioned. Now, for time-sensitive surgery, as mentioned, you would need multidisciplinary evaluation, and it is individualized whether you would need a perioperative assessment of the patient before the actual surgery. Now, for elective NCS, you would need the following things with the class 1 recommendation. Of course, you want an accurate history, clinical exam, including standard lab tests such as creatinine and CBC. And you should advise patients to stop smoking. So counsel smoking cessation amongst patients who are cigarette smokers, like our patient who is a 20-pack-year smoker, and optimize guideline recommended medical therapy based on their comorbidities. So for smokers out there, remember to stop smoking at least 4 weeks before your planned NCS because it is the time frame that could actually reduce your post-operative complications and mortality. All right. Then patients should then be stratified into one or the 3 categories. And let's start with the less problematic group. These are the young patients or less than 65 years without any cardiovascular disease and cardiovascular risk factors, such as you see on the screen. Now, for these patients, you don't need a cardiac evaluation for low risk and intermediate risk NCS. But for high risk NCS, you would need an ECG and biomarkers with a class 2A recommendation. And for patients who are also more than 45 years for high-risk NCS, consider doing these 2 tests. Now, for patients who are relatively old, more than 65 years old, or with cardiovascular risk factors, or patients who already has established cardiovascular disease, low-risk NCS, again, no need for further testing. But for intermediate risk NCS, it's the same. But for high-risk NCS in patients with established cardiovascular disease, cardiology consultation plus multidisciplinary discussion is recommended in these patients. Now, when are we going to do your 2D echo? So, 2D echo is only recommended for patients who has a family history of a genetic cardiomyopathy, or if you have newly detected murmurs that are about to undergo a high-risk NCS, and for patients with poor functional capacity and or elevated natriuretic peptides. Okay, so I've been mentioning about functional capacity time and again. How do we quantify it? So it's actually a pivotal step in preoperative cardiac risk assessment. Personally, I always ask this regardless of the risk of the patient. And in recent large prospective cohort study of high-risk patients undergoing in NCS, they found that self-reported inability to climb 2 flights of stairs added to the incremental value of the 30-day cardiac event rate. So basically, patients whose metabolic equivalence of less than 4 is considered to have poor functional capacity. So ask your patient if they can still be able to climb 2 flights of stairs or climb up a hill. Then we proceed to the biomarkers such as your natriuretic peptides and your troponin. So it can be able to detect and quantify prognostic aspects of cardiac involvement. So it may aid also in our evaluation. So just an update, your biomarkers are actually promoted, upgraded in the guideline recommendations. Your natriuretic peptides has a class 2A recommendation, and their purpose is basically to diagnose heart failure among elderly patients that are most often would undergo a non-cardiac surgery, and to intensify treatment among patients who already has heart failure. Now, for high sensitivity troponin T and I, it has a higher recommendation at class 1B, since it's widely available, it's less expensive, and it also enables us to diagnose an acute MI and an accurate diagnosis of perioperative myocardial infarction, which later on we will discuss in more detail. So this is the complete recommendation of your troponins. It's recommended for patients who has cardiovascular disease, cardiovascular risk factors, including age more than 65 years, equal or more than 65 years, symptoms suggestive of cardiovascular disease, and you have to measure it before intermediate and high-risk NCS and day 1 and day 2 post-op. Now, since our patient belongs to this group, then we should do additional ECG and high-sensitivity troponin, as also recommended by the earlier algorithm. Then repeat it after 24 hours and after 48 hours of the surgery. We should compare any changes on your cardiac troponins, and if it's there is an elevation above the upper limit, then it's considered as perioperative myocardial infarction. So the other definition of PMI is if there is significant increase of the concentration, or if it increased more than 5 times the upper limit. So that can also be used as diagnosis for PMI. So it should trigger ECG recording and another detailed clinical evaluation of your patients for workup, which we will go to the next thing. So this is the systematic workup and treatment for perioperative myocardial injury or infarction. First, we need an ECG and ask for symptoms such as typical chest pain and also determine the patient's hemoglobin. So if there are changes like ST elevation or ST depression and typical chest pain, check for the hemoglobin. If it's less than 8, then you have type 2 NI. So what you need to do is to transfuse, then reassess if you would need an invasive coronary angiography. If the patient doesn't have severe anemia, meaning the hemoglobin is not less than 8, then treat the patient as a type 1 myocardial infarction. Now, if the ECG is negative and the patient doesn't have chest pain, the next step is you do a 2D echo just to check for the other potential cardiac cause such as an acute heart failure, a valve issue, or tachyarrhythmia, and treat them accordingly. If it's still negative, consider non-cardiac cause such as sepsis, pulmonary embolism, and stroke. Now, if it's still negative, you should repeat your hemoglobin again, check for severe anemia, and also investigate for potential hypotension because your patient may have a type 2 MI or a missed type 1 MI. And again, you should treat them based on guidelines. All right. Now, going back to our patient. So she's still on aspirin, 80 milligrams, 1 tab once a day, and aticagrelor, 90 milligrams, 1 tab twice a day because she had coronary artery disease, and she said that she had a PCI done about 7 months ago. And the anesthesiologist was like this. So what would be your course of action before the anesthesiologist would have a heart attack? So this is your algorithm for patients who are on dual antiplatelets in the perioperative period. So dual antiplatelet usually consists of an aspirin and a P2Y12 antagonist, and it's used in multiple clinical contexts. So PCI is one in order for us to be protected from recurrent myocardial infarction and stent thrombosis. But other patients would also use this if they have secondary stroke prevention after ischemic stroke and following certain peripheral endovascular interventions. Now, for patients who are about to undergo surgery and they are on dual antiplatelets, the benefit of your DAPT in terms of thromboembolic prevention must be weighed against the bleeding risk. So the first thing that we need to find out is the bleeding risk of the patient's surgery. So in the guidelines, they have this. It's a very nice table. Again, unfortunately, our patient belongs here, which is of high risk, high bleeding risk surgery, which is a major orthopedic surgery. And so, because if it's not of high bleeding risk, then there's no problem. We just let our patient continue their dual antiplatelet therapy and proceed with the NCS. But since it's a high bleeding risk NCS, then you should determine the thrombotic risk of our patients, which includes if the PCI is less than a month old, or the patient had an ACS for less than 3 months ago, or is of high risk of stent thrombosis, such as the following conditions. And so as you can see, I put in the patient's HbA1c and creatinine just to show you that the patient has controlled diabetes and doesn't have severely impaired renal function. And so since the answer is no, the recommendation is still to continue aspirin and interrupt your P2Y12 inhibitor since the patient is on ticagrelor. So advise the patient to stop it for 3 to 5 days. Then the patient may go ahead with the NCS. Now, what if the patient is of high thrombotic risk? You should find out if it's a time-sensitive NCS. If not, then consider deferring it because it may be safer. But if it's a time-sensitive surgery and after the multidisciplinary evaluation, you would need to proceed with the procedure, then bridge with the GPI or a glycoprotein 2B or 3A inhibitors or acangrilor. Because the preferred management of patients who are on dual antiplatelet due to PCI is ideally to delay the elective NCS until the completion of the full course of the APT. And that is 6 months after an elective PCI and 12 months after an ACS. However, there are several recent trials that indicated that we can shorten your DAPT duration to 1 to 3 months after implantation of your modern drug-eluting stents. And it's associated with acceptable MACE and stent thrombosis. So remember, it has a class 2A recommendation, a lower recommendation, but it can be done, but only for patients who has an elective PCI. For patients who had an ACS, ideally, it should be completed for at least 6 months. Now, in the resumption of your dual antiplatelets, it should be done as soon as possible, ideally within 48 hours, or as soon as it is safe to do so from the standpoint of surgical hemostasis, or as long as the surgeon clears it that it's okay to restart. Now, for patients who are on oral anticoagulant, it would again depend on the surgery and patient-related factors and the specific oral anticoagulant that the patient is taking, whether it's a non-vitamin K antagonist or a vitamin K antagonist or a warfarin. So remember, if the patient is to undergo a high bleeding risk NCS and is of high thrombotic risk, the only situations that you would consider bridging would be mechanical heart valve patients and patients who are at very high thromboembolic risk, such as these types of patients. Because in the guidelines, they don't push for bridging anymore because they noted that there's a higher incidence of bleeding in these patients. So these are the only two conditions that you would consider bridging. Now, if the patient will not undergo high bleeding risk NCS, then you can interrupt your warfarin and your NOAC. Your warfarin, you can still continue, but aim for a lower INR goal. And in the resumption, it should restart at 12 to 24 hours after the invasive procedure and restart your dose by a boosting dose of 50% for 2 days, specifically for warfarin. Again, I told you it's a 99 pages document. So there are other specific diseases. There's a lot of information there that you could get in the guidelines. So please read on them. And I hope you learned something tonight. And you will be more confident also in clearing your patients before an NCS. Thank you.
Thanks, Ruchi. Great talk. Very comprehensive. So yeah, some important things from your lectures are not only we have to see the risk of CVD in operative patients, we also need to see the risk of operation in CVD patients. Very nice. Probably, Prof. Juang, do you have any take on this issue about assessing the operative patients? Hello, Prof. Juang?
Yeah.
Do you have any on the presentation?
Yeah, I think the Dr. Cruz very good presentations. I think this is very difficult and complicated the topic, and then you did a good job. You just showcase and give us some idea how to run through the flow chart and clearly. And I think this topic is very important. We guys are facing every day. Like my patient, he's a 90 years old woman, and he had ischemia heart, put on the stent years ago with a little bit heart failure, and she's going to do PCN, there's a put a tube for right kidney hydronephrosis. So 90 years old woman, I think family always asks, is the risk is high? And for us as cardiology, it's very difficult because there's no very good RCT trial or some clinical observation study data to tell us which one is best, which best is best. I think it will be individualized, but the guideline gave us some direction, but we have to treat patient case by case. And I think the way explanation to the patient and family is the key. So to let them understand, no zero risk, always has some risk. Always tell them low risk, intermediate, and high, and we will do our best. I think that's my clinical experience, because the patient does have some heart disease, especially have some abnormal biomarkers. That's my opinion to all you guys. You guys can make some comments. Maybe Dr. I'm sorry. You may have some comment more.
Probably you can follow up on those comments, Richie.
Yeah, I agree, Prof. Actually, in the guidelines, that's the reason why it took them so long for an update, because there's really not much RCTs for patients who are undergoing surgery. And it's true, no? Even in practice, Prof, most of the time, I also, just to be sure, I would like to see an echo first, no? Even if in the guidelines, there's a very short list of patients that you should do it. But I would also like to add that in the guidelines, what I like about it is they also included frailty measurement. So especially for very old patients. So I think that would also guide us and also the relatives and the patient if they would want to still pursue with the procedure. If the patient is really frail, no, it's also associated with increased mortality and morbidity in the surgery. Then it's good that they also included and mentioned it in the most recent guidelines, Prof. Thank you, Wishnu.
Yeah, it's never easy.
Hi.
Yeah, you have any follow-up on that, Prof. Juang?
Hi, can I add one more comment? Can you hear me?
Yes, please.
Yeah, if I can just highlight one more perspective is we as cardiologists always do think in the way how we can facilitate the patient to undergo necessary surgery, the indicated ones. I remember what I want to highlight is the interdisciplinary discussions. I remember a recent case of 60, 70 years old female with a oncological conditions, concomitant severe AS, multivessel disease. So from cardiology point of view, some might think, oh, he has intermediate stage cancer, why would we bother with cardiac procedure? And from the surgeon's perspective, oh, she has multivessel severe AS, why would we bother with your oncological surgery? So in the end, we sit down and talked twin teams, and we came into consensus. We had the aortic stenosis, we treated coronary arteries, and she successfully underwent the oncological treatments. I think it's important to highlight interdisciplinary discussions. Sometimes we don't know what other teams are thinking, and they don't either. Another example is, my wife works in obstetrics, and she recently had a case, young female, pulmonary hypertension, entering pregnancy, systolic pulmonary pressure was 80, 90 at gestation, 20-something weeks. Very tough case. And she was given all the inhaled nitric oxide, inhaled hydrotrost, IV epoprostenol, all medications put just stuff into that lady. But with multidisciplinary discussions between cardiologists, ICU, obstetrics, so they even decide to, during the deterioration in 28 weeks, I guess, they initiate the APO before taking the baby out. So I think I just want to highlight the interdisciplinary discussion, which is pretty much very important in my mind.
Yeah, I do agree. We sometimes call it family meeting with the patient, and the multidisciplinary care, and also shared decision making, SDM.
Thanks, Prof. So I think time's up. So we're already 3 minutes late. Let me share something which I think probably can conclude all the talk today. So we all already heard 3 presentations today, very nice, and also heard some expert opinions from Professor Juang. And I think these are the things that we can take from today's presentation. First one is to conduct your assessment with technical accuracy, such as the QTC measurement in QT syndrome, and also understand the statistical interpretation of the results. We should know how to correctly and safely provoke a suspected channelopathy, as Julian has addressed. From Derek's presentation, we know that we have to understand the types of cardiomyopathies, and we should look forward to further specific interpretation with cardiac MRI and also genetics. And from Professor Juang's opinion, we should be aware of the approximate probabilities in sudden cardiac death syndrome. And this is not a fixed number, but probably a little bit more on channelopathies and almost about 40% in cardiomyopathies. We'll see how it goes. And we should learn how to appropriately assess not only the CVD risk in non-cardiac surgery, but also the risk of the operation in CVD patients. And we should understand the various bleeding and thrombotic risk scenarios in progressive patients. And not to mention the last one that Derek states about the importance of communication and interdisciplinary cooperation between the physicians. So with that, I think I would like to close the session. We'll say a big thank you to all the expert speakers and also Professor Juang as our expert panelist today. I personally really enjoyed this session and looking forward to another APSC-EECC Core Cardiology General Review with you all. Thanks a lot and have a good day.
Yeah, bye-bye.
Excellent, thank you.
All guys, all the moderator, Dr. Jyh, and all speakers and audience to join these sessions. Looking forward to see all guys in the meeting, the APHRS or ESC in the future.
Yes, sure. See you around. Bye.
See you.
Thanks a lot.
Bye-bye.